Hi everyone, we're into video 3 of section 13 and we are starting with chapter 68 and we're going to be talking about anxiety, stress, and trauma-related disorders. For all of these next slides, be sure and review content in the book as we are going to hit the highlights and not delve in too extensively. First, we're going to talk about generalized anxiety disorder, and it's characterized by excessive worry that's been going on for over 6 months with multiple concerns that are difficult to control. It is something that you may see quite commonly in primary care. General anxiety disorder is more disruptive than normal anxiety, and it's characterized by apprehension and can have physical symptoms such as headaches, stomach issues, etc. Approximately 50 to 90% of patients that have general anxiety disorder also have another comorbid mental disorder such as depression. So the DSM-5 classifies anxiety disorders into 6 categories. You can have generalized anxiety, anxiety disorders due to a general medical problem, substance-induced anxiety, anxiety disorders not specified, acute stress, and post-traumatic stress. As we mentioned, the main criteria is excessive worry and anxiety for greater than 6 months. The intensity, duration, and the frequency of the anxiety and worry are out of proportion to the actual likelihood of the impact of the feared event. This condition can have many physiological symptoms. These individuals can have breathing difficulty, impaired concentration. They can feel that they're having palpitations, sweating. There can be sleep disturbances. With these patients, patient education is very important to help them identify symptoms and effective interpretation of physical symptoms. It's important that they are aware of stimulants that can increase their anxiety, such as nicotine and caffeine, and then being aware of the benefits of relaxation therapies. And while medications and counseling individually can be beneficial, combined they are much more effective. In the pharmacological management of GAD, generalized anxiety disorder, the SSRIs are the first line of treatment and are particularly helpful if a patient already has coexisting depression. Lexapro, Paxil, and Zoloft have been shown to help put GAD symptoms in remission and definite reduction in these symptoms. SNRIs such as Effexor and Buspar are also helpful in the treatment of generalized anxiety disorder. The goal with all of these medications is to reduce and relieve symptoms to enable the patient to be able to take care of themselves properly and to manage their anxiety. Page 1132 and 1133 has commonly prescribed anti-anxiety medications, so I encourage you to review those. Follow-up appointments are very important for these patients, and it's important to make sure that they're not too much, but they're also effective in their follow-up appointment. It's important to have a plan that decreases, helps them to decrease the symptoms that they are having, as well as assessing for any issues that they might present with for suicide or possibly even homicide. And there needs to be thorough documentation of your evaluation and plan in the chart. Sorry for the pause. Just to make you aware, we had a great coalition meeting last month talking about psychopharmacogenetic testing, and that's where you are using more personalized medicine. It's testing to see what medication the patient may be receptive to, and I think that we're going to see more and more of this in the future. There's a column about it on page 1134, so I encourage you to read that. It is more popular with psychiatric medications right now, but I do think that it'll be something we'll see in the future. Moving on to panic disorders, and these usually present in young adulthood, and it can impact a person's social, family, and work lives. It's a combination of a sudden onset and increased severity of panic symptoms that create secondary symptoms of fear. And this fear is what drives individuals to seek emergency care. As we mentioned, it typically appears in late adolescence or early adulthood with a peak of about 25 years, and then may have a second peak between 35 and 44. And panic disorders impact women twice as much as men. When you're assessing your patients, it's important to assess for risk, and patients with a family history of panic or anxiety disorders are more likely to suffer from them themselves. And then if there's other psychiatric issues such as depression, bipolar, or substance use, they are more likely to have panic disorders. In the treatment of panic disorders, SSRIs and SNRIs are widely used. They are recommended as first-line pharmacological therapy for panic. Other medications that can be used in the management of panic disorders include your tricyclic antidepressants, benzodiazepine, valproic acid, gabapentin, but as with always with benzos, they should be only used in certain extensive circumstances, and only when a patient is unable to tolerate an SSRI, SNRI, or a tricyclic antidepressant. And as with all of these, most of these conditions, CBT plays an integral part along with medications in the management of panic disorders. The literature also suggests that using CBT in panic disorders, these patients have longer periods of remission and longer term benefits from treatment. In practice, when you're managing medications for panic disorders, it's recommended to follow with these patients 1 to 2 weeks after starting treatment, and then every 2 to 4 weeks until therapeutic dose has been achieved on your medication. Next, let's talk about PTSD, and we know that this is a syndrome that can develop when someone participates in or experiences direct exposure to an actual or a threatened trauma. There can also be an indirect exposure, and this is often seen for professionals such as first responders and medics that may lead to the development of PTSD. The reaction is typically a sense of fear and helplessness as they relive the event over and over and try to avoid being reminded of it. There are several risk factors that are associated with PTSD. These include physical and sexual child abuse, a sexual or other life-threatening assault, combat exposure, being involved in a fire, flood, some type of natural disaster, witnessing someone being killed or badly injured, history of mental health issues, and refugees resettled into Western countries. The main clinical features of PTSD are painful re-experiencing of the event. They may have patterns of avoidance and emotional numbing. Our slide mentions different symptom categories. This includes having intrusive thoughts about the traumatic event, avoidance symptoms, which may include activities that might revive those memories, so they try to avoid those. And then hyperarousal symptoms. These are symptoms of feeling on edge. Your patient may have unprovoked anger, feel jumpy, may feel like they're on guard a good bit of the time. Treatment of these conditions includes SSRIs such as Paxil and Zoloft. Those have been approved for PTSD. Follow-up with these patients may definitely need to include referrals out to a psychiatrist or to a mental health nurse practitioner. Next, briefly, sexual assault is any unwanted sexual behavior against the person's will or lack of consent due to age, disability, or being under the influence of alcohol or drugs. Associated with this is a sexual assault trauma syndrome. and it's a person's response to the sexual assault. There are two identified phases of survivor's response, the first being the initial or acute phase, and that's characterized by a period of disorganization, and then long-term where there's a period of reorganization. As the provider, it's important to assess when this assault happened. If the sexual assault has occurred within the last 72 hours, then forensic physical evidence should be collected. The use of a SANE nurse, a sexual assault nurse examiner, who has special training in collecting forensic evidence and providing crisis intervention, would definitely be an asset on your team as you're trying to help this person. Follow-up for someone with sexual assault would trying to help them to be aware of support services that are available in the community, and then getting them individual or group therapy as needed. Next, we're moving on to chapter 69 and talking about obsessive compulsive disorder. And this is condition is characterized by obsessions, compulsions, or both. And we know, just as a refresher, obsessions are recurrent and persistent thoughts, urges, and images, and compulsions are repetitive behaviors or mental acts that we feel forced to perform to either due to either an obsession or strict rules of conduct. Sorry, the slide didn't move forward. It's the fourth most common mental health illness after depression, alcohol and substance abuse, and social phobias. It can start in early childhood, late adolescence, or early adults. Males typically have an earlier onset, whereas females are diagnosed at a later age. The book offers some great screening questions for OCD that could easily be incorporated into your day. So I want you to look at those on page 1154. These can include, are you ever bothered by frequent thoughts that are senseless but that you can't get out of your head? Do you repeatedly check things like locks, plugs, or burners? There's also on page 1155, table 69.1, common OCD symptoms and presentations. And it's broken down into obsessions and compulsions, and then gives examples of each. So I would encourage you to look at that screen. For medical management, your SSRIs are recommended as the first line agent in the management of OCD in kids and adults. And I know we're not talking about kids here, but the book has spent some time on that. Just to be aware, all SSRIs are approved for OCD by the FDA except for Lexapro and Celexa. And as we have mentioned before, CBT is also recommended as a combined modality with your SSRIs. The book has a detailed section on differential diagnoses for obsessive compulsive disorder, so I encourage you to look at that section. We are not going to get into body dysmorphic disorders. You can read about that in the book. We're not going to get into hoarding. You can read about that in the book. We're going to move on to chapter 70 and talk briefly about eating disorders. And although they are not as commonly discussed in primary care, it's important that we're aware of them. And there's 5 different eating disorders: rumination, avoiding foods, anorexia, bulimia, and then a binge eating disorder. All of these can have significant impacts on your patient's physical health as well as mental health. There's an excellent focus on history for your eating disorders on page 1168, and these are some warning symptoms that you need to be aware of that could your patient have an eating disorder. Has there been substantial weight loss? Does the patient have signs and symptoms of depression and mood swings? Is there preoccupation with weight, calories, and food? Does the patient have a history of excessive exercise? Physically, you may notice that there's been weight loss, emaciation, cachexia. There could be changes in the hair and skin. There could be swelling to the extremities. On vital signs, there could be low blood pressure, low temperature. On their labs, you may know that they have a low white count. They could have anemia. They could have an elevated liver function test. You may notice that they have low magnesium and low phosphorus levels. Other symptoms may include patients that have stopped having periods, constipation, abdominal pain, being cold all the time, lethargy or fatigue, having this anxious energy, and headaches. It's important to determine if these patients need to be hospitalized, and the book lists several factors to bring into account. Is their weight less than 85%? Any suicidal ideations, if they're physiologically unstable, or if they lack response to outpatient treatment. In the outpatient setting, it's important though to build trust and a therapeutic alliance. You want to work with your patient that may have anorexia or bulimia and set target weights. Antidepressants, especially the SSRIs, have become widely used in the treatment of eating disorders. Prozac is the only FDA-approved drug for bulimia, so just be aware of that. These treatments for eating disorders require specialized care, so these are going to be patients that you're going to refer. Next, we're going to talk about sleep issues, and these are things that are probably going to be more common for you in practice. And these are going to include insomnia, obstructive sleep issues, and restless leg syndrome. As with many of our conditions, asking the pointed questions in your history taking can give quite a bit of information about your condition. The book mentions on page 1168 questions to ask regarding the patient's quality of sleep. Have they been having difficulty sleeping? Do they travel frequently? Their use of caffeine. So I want you to review those. It's also important for your patient to keep a sleep diary over the previous 2 to 4 weeks, so that you can see a better idea of exactly what's going on, what conditions might be impacting the patient, as well as the impact that diet, exercise, and any drug use may have on the insomnia. The DSM-5 breaks down insomnia into clear-cut criteria, but some common symptoms include poor quality of sleep, difficulty falling asleep, staying asleep, or early morning awakening, and then trouble sleeping that is not the effect of medication or drug. Sleep hygiene is very important, and the book details this on page 1170. So it's important that your patient try to be maintaining regular sleep and wake schedules, and that's 7 days a week. Eating regular meals, relaxation, limiting screen time, limiting caffeine, alcohol, tobacco later in the day, those type of things. It also talks about different interventions that nurse practitioners can do for the management of insomnia, and that's on table 70.1. So I encourage you to review those. And then on page 1171 are listing of medications that are used to help with sleep, sedatives and hypnotics. So be sure and review those. Next we have restless leg syndrome. We're almost done. This is a neurological sensory motor condition that results in uncomfortable sensations in the lower legs, typically seen with burning, tingling, crawling, or itching, and the uncontrolled desire to move their legs around. Symptoms often occur when the patient is at rest and often worsen at nighttime when attempting to go to sleep. Management of restless leg, along with good sleep hygiene, other management techniques could include baths, whirlpool, massage, exercise. The FDA has approved a vibrating pad that is called Relaxis, which counter-stimulates the sensation in the legs. And then also FDA has approved pramipexole and ropenolol to be used at bedtime for restless leg syndrome. The book now talks on neurodevelopmental disorders on chapter 71, and I disagree with them, as most of these following conditions are diagnosed at childhood. So we're not going to go into details about them. I want you to be sure and read read about them. We discuss this more in the pediatric class in more detail. You may see patients in practice that have several of these conditions, but the diagnosis has likely already been established, or if you are concerned and are working towards a new diagnosis, then these are all patients that are going to be referred to psychiatry to help with the diagnosis and treatment. So I think that's the end of section 13. It was a long section, and I appreciate your attention. If you have any questions, please feel free to reach out. Thanks.